evening. Please take your seats, relax. So welcome to everybody. Thank you so much for making the time to be here. We're here at a wonderful, wonderful university event, and that is for an inaugural lecture, when we get to hear a professor profess. Now, before I do anything formal, I just want to let you know my name is Ian Jandrell. I'm a Deputy Vice Chancellor, and I have the absolute privilege of working quite closely with this faculty. But I think I should say in front of the Dean of the Faculty of Health Sciences that I'm an engineer. So when I come to these events, as long as the inaugurating professor speaks slowly and loudly, I'm going to pick up a little bit of what you say. But it's wonderful to be with all of you. Thank you for making the time. Folk, we are going to be doing a recording of the event tonight, and my understanding is that we will always have these available in perpetuity on YouTube so that one can always look back on these incredible events. My job is actually very simple. I want to introduce to you the procession. The procession included the Dean of the Faculty of Health Sciences, Professor Shabir Mahdi, Professor Feroza Mutara, the Academic Head of Division, Emergency Medicine, and you will hear from her later, and of course our inaugurating professor, Professor Abdullah Lahe. Congratulations, thank you very much, and all I'm going to do now is ask the Dean of the Faculty, Professor Shabir Mahdi, to introduce our inaugurating professor, Professor Lahe. Thank you, Shabir.
Thank you, Prof. General, and good evening, colleagues. Welcome to the inaugural lecture of Professor Abdullah Lahe. So Professor Abdullah Lahe is Professor at the Division of Emergency Medicine and Senior Consultant at the Charlotte Mokeke Johannesburg Academic Hospital Emergency Department. He has over 80 publications in ISI DNE accredited journals, is a peer reviewer for a number of international journals, and has supervised over 20 MEd and MSc dissertations to date. He also lectures at both the undergraduate and postgraduate levels, and he is the course coordinator of the second-year MSc program in emergency medicine. He is also the chair of the Research Assessment Committee for Emergency Medicine and also serves as an examiner for the College of Emergency Medicine. Professor Lahe, congratulations on your achievement and your promotion, and hand over to you to give your talk.
Thank you, Professor Mahdi, and thank you to Professor General for those kind words. I will start by extending my greetings to the Chair, Prof. General, the Dean, Prof. Mahdi, Head of School, Head of Department of Emergency Medicine, Prof. Feroza Mutara, my supervisors and mentor, Prof. Richards, who's up there, and to all of my other mentors, colleagues, friends, and other attendees. I am extremely grateful for this opportunity to deliver this talk, which is based on one of my fields of research interest. I am extremely grateful to my almighty creator, my wife and family, my HOD, my study supervisors, my seniors and teachers and mentors, my friends and colleagues, and patients, and not forgetting study subjects, and all others for their continual and enduring support, assistance, patience, and guidance over the years. I have no conflicts of interest to declare. And I will start off by mentioning that as we speak, the 25th International AIDS Conference has commenced yesterday in Munich with over 15,000 participants. Now, for those of us that have missed our flights to Munich, this lecture is only a minor consolation and your punishment for the next hour or so for not attending the international conference. So since the first case of HIV was reported in 1981, there has been 85.6 million people that have acquired HIV globally, of which 40.4 million have died from AIDS-related illnesses. Okay. And hot off the press, just published yesterday, the latest UNAIDS annual report, very relevant to today's topic of discussion, with some excellent timing by the university for scheduling this talk for today. Right? And Crossroads, and we see it's entitled The Urgency of Now, AIDS at a Crossroads. Crossroads can be defined as a point at which a crucial decision must be made, which will have far-reaching consequences. And from the press release, new AIDS report shows that AIDS pandemic can be ended by 2030, but only if leaders boost resources and protect human rights. And here it's mentioned that the world is at a critical moment that will determine whether world leaders meet their commitment to end AIDS as a public health threat by 2030. So I'll just start off by going through some of the recently published stats from yesterday's press release, yesterday's publication from the UN AIDS. So currently there are 39.9 million people living with HIV. So these are 2023 stats that were released yesterday. 53% of all HIV positive patients are female, 96% are older than 15 years, and 86% are aware of their status. 77% of all HIV positive patients are currently accessing antiretroviral therapy, which translates to 30.7 million of the 39.9 million people. Among the 86% who know their status, 89% are accessing antiretroviral therapy, of whom 93% are virally suppressed. In 5 countries, some of them are our neighbors, Botswana, Swaziland, Rwanda, Tanzania, and Zimbabwe, have achieved the 95, 95, 95 targets. Just to remind everyone, what are the 95, 95, 95 targets, which are to be achieved by the end of 2025? That's 95% of people living with HIV to be aware of their status, 95% of those aware of their status to be on antiretroviral therapy, and 95% of those on antiretroviral therapy to be virally suppressed, and for there to be less than 370,000 new infections annually from 2025 onwards. So in 2023, there were 1.3 million newly infected people, newly infected HIV positive people, which is a 39% decrease since 2010, when there were 2.1 million people with HIV, and a 59% decrease since the peak of the HIV epidemic in 1995. Fewer people have acquired HIV in 2023 than at any other time since the late 1980s. However, still more than 3 times higher than the target. This is still more than 3 times higher than the target of less than 370,000 new infections that we need to achieve by the end of 2025. Sub-Saharan Africa achieved the steepest reduction with a 56% reduction. There are concerns for rising numbers of new infections in Eastern Europe, Central Asia, Latin America, the Middle East, and North Africa regions. For the first time, and this is significant, for the first time in the history of the HIV pandemic, more new infections are occurring outside Sub-Saharan Africa than in Sub-Saharan Africa. So which is good for Sub-Saharan Africa, but not good for the rest of the world. 630,000 people died from AIDS-related illnesses in 2023, and compared to 2010 and 2004, this translates to a 51% reduction and 69% reduction since 1995. 52% of all HIV-positive patients live in Eastern and Southern Africa, which means half of the world's HIV population currently live in Sub-Saharan Africa. 8.5 million in South Africa, so 8.5 out of 40, which is more than 20% of the world's HIV population living in South Africa. That is more than twice of any other country in the world. In Sub-Saharan Africa, adolescent girls and young women accounted for more than 77% of new infections among young people aged 15 to 24 years. And females were 3 times more likely to acquire HIV than their male peers in Sub-Saharan Africa. With regards to Eastern and Southern Africa, they had the largest decrease in new infections. From 2010 to 2023, there's been a 59% and 57% reduction in new infections and AIDS-related deaths. With regards to funding, a total of $19.8 billion was available for HIV programs in low and middle income countries in 2023, almost 9.5 billion short of the amount that will be required in 2025. So we're 3/4 way there, or 2/3 of the way there. Some stats for South Africa. So as was mentioned, 8.5 million people living with HIV in South Africa, which is a 29% increase since 2010. So one may ask that why, since we're doing so well with the epidemic, why has there been an increase in the number of people living with HIV? And that's because there are more people on antiretroviral therapy and less people are dying. There's been a 51% reduction since 2010 in new infections and 73% reduction in AIDS-related deaths. Almost twice as many women aged more than 15 years acquired HIV in 2023, which means that 89,000 women compared with 50,000 men. And 94% of people living with HIV know their status. 74% of people living with HIV are on antiretroviral therapy, and good that 96% of pregnant women as well. And 2/3 of people living with HIV are virally suppressed in South Africa. 234,000 have comorbid tuberculosis. So the availability of antiretroviral therapy globally has significantly reduced HIV-associated morbidity and mortality rates worldwide, and life expectancy of people living with HIV is now comparable to that of the general population. So almost like a chronic illness like diabetes, hypertension, etc. We all know previously in the past, in the early days when there wasn't sufficient therapy for diabetes, diabetes was almost like a life sentence. Nowadays, you're diabetic, there's insulin, there's oral therapy. So similar for HIV. Previously, in the early days, we all know that HIV was a life sentence when there wasn't sufficient or widespread access to antiretroviral therapy. Nowadays, it's almost like a chronic illness. You got HIV, take your pills, and you should be okay. However, the burden of acute HIV-related illnesses is still substantial, especially among those who are newly diagnosed, those not on antiretroviral therapy or non-adherent, and those that have resistance or are severely immune deficient. And loss to follow-up remains a problem despite growth in the numbers of patients starting on antiretroviral therapy. For the rest of the talk, I'm going to be focusing on acute HIV, that's HIV in the emergency department and ICU settings. So just some background with regards to HIV in the ICU setting. So 5 to 10% of hospitalized HIV-positive patients require ICU admission, obviously dependent on the setting where you are in the world. 40% are only diagnosed after admission to ICU, meaning that these patients were not aware that they were HIV positive until they had been admitted to hospital and into the ICU. Rates of HIV-related ICU admissions have been lower since the introduction of antiretroviral therapy. CD4 cell count, and surprisingly, CD4 cell count and HIV viral load were not shown to predict ICU survival in some of the studies. There is limited data on the outcomes of HIV and HIV-positive ICU patients in developing countries. So this was one of the first publications regarding this topic. It was one of our master's students, published in the journal HIV Medicine. The study was a retrospective chart review of HIV-positive adult patients admitted to the Charlotte Macheca Johannesburg Academic Hospital ICU a year next door during the 2017 calendar year. 22% of the 903 total admissions were HIV positive, which is, so our sample size was 204 patients. Approximately half of the number of patients were admitted with a sepsis-related illness. A third were admitted for post-operative care, so required some type of surgery, and after surgery required some ICU monitoring. And a fifth of patients, almost 20%, were admitted with a non-sepsis-related illness. The median length of ICU stay was 5 days. And 21.5% were only diagnosed with HIV after ICU admission, as compared to previous studies which showed up to 40%. Okay. A third of patients were not on antiretroviral therapy prior to admission, and the overall mortality was a staggering 33.3%, which means that if a patient is HIV positive and requires admission to the ICU, 1 in 3 patients would not survive. So some characteristics of our study subjects, and we can see the median age was 40 years. For every year increase in age was associated with a 3% higher odds or higher likelihood of mortality, of in-hospital mortality. Then we see most of the subjects were female, 59.3%, and with patients with sepsis and non-related and non-sepsis related diagnoses were 3 times, 2.87 and 3.05 times more likely to be more likely to die. Okay? And also very significant, patients who required inotrope or vasopressor support or mechanical ventilation had a 16 times higher likelihood of mortality, ICU mortality, and 12.2 times higher likelihood of ICU mortality. And we note as well that almost all patients who died required either inotropes or mechanical ventilation. Likewise with hemodialysis, 2.74 times higher likelihood of in-hospital mortality. And then we also looked at the Apache 2 scores and the SOFA scores. So Apache 2 and SOFA scores are outcome prediction scores or outcome prediction models that predicts ICU mortality. And here we note that for every point increase in the Apache 2 score was associated with a 11% higher likelihood of in-hospital mortality. Okay, the data was then subjected to multivariate analysis to determine independent predictors of ICU mortality, and from here only 3 variables came up, so inotrope vasopressor support, mechanical ventilation, and being admitted with a non-sepsis related diagnosis. We thereafter went on to calculate the risk-adjusted mortality ratio, which can be defined as observed ICU mortality, so the number of patients that are actually dying, divided by the Apache 2 predicted ICU mortality rate. So as we mentioned, the Apache 2 score is an outcome prediction model. So based on that model, it tells you what's the likelihood of mortality of dying. And our calculation came out to 0.51, which means that this indicates that the Apache 2 score overestimated ICU mortality in HIV-positive patients by approximately 2-fold. Okay, so meaning that the tool should not be used. Apache 2 score or tool should not be used. Should not be utilized as a criteria to determine eligibility for ICU admission in HIV-positive patients, and therefore this is a research gap. There is a need to develop a specific outcome prediction model for HIV-positive patients requiring ICU care. Then the next part of our research was regarding HIV in the ICU. So emergency departments are frequently the first port of call for people living with HIV experiencing an acute deterioration in health. And this was the title of our study. It was conducted at the Charlotte Macheke Johannesburg Academic Hospital Emergency Department. Okay. And this was also the topic of my PhD. 5 publications emanated from this research. Okay. And the first of the publications, so we looked at the profile of presentation of patients that presented with HIV or HIV-positive patients. This was published in the South African Journal of HIV Medicine. So the entire study was a single-center prospective study, cross-sectional, conducted at CMGH ED. Data collection spanned from July 2017 to October 2018. That's 16 months. And our inclusion criteria were all consenting HIV-positive patients that were managed at the emergency department. A total of 1,224 patients were recruited and included in the final study sample. Median age of study subjects was 36 years, and 55% were female. This is how we got to the final sample of 1,224. We had approximately 30,000 patients that came through the door, emergency department doors during these 16 months. Many of them were triaged out to lower level care facilities, as Charlotte Macheke is a quaternary hospital. Of the 11,000 remaining patients, 7,000 plus were HIV negative, and approximately 2,000 did not consent to testing. And from all those that were HIV positive, some did not consent to study participation, and we ended up with 1,224 patients in total. Okay. So a total of 17.3% were newly diagnosed with HIV at ED presentation. 3/4 of patients who knew the status were not on antiretroviral therapies. Were on antiretroviral therapy, meaning that 25% were not on antiretroviral therapy. A third of those on antiretroviral therapy were not adherent to the therapy, and approximately half of the patients had immunological failure. That's a CD4 cell count less than 100. Approximately 60% had virological failure. That means the viral loads were more than 1,000. Approximately 20% were diagnosed with tuberculosis, of whom 58.6% had extrapulmonary tuberculosis, meaning that if patients coming to the emergency department, HIV positive patients, and being diagnosed with pulmonary tuberculosis, we cannot stop there. We need to search for extrapulmonary tuberculosis, which may affect duration of therapy. So the most common presenting diagnoses were bacterial pneumonia in approximately a quarter of patients, pulmonary tuberculosis, acute gastroenteritis, PJP pneumonia, cryptococcal meningitis, bacterial meningitis, and chronic gastroenteritis. 16.7% of our patients were admitted to the ICU, and approximately a third of patients had a prolonged length of stay, which we defined as length of hospital stay more than 7 days. Our overall in-hospital mortality was 13.6%. So it is concerning that despite the free availability of antiretroviral therapy to all South African people living with HIV, over 2/3 of study participants presented with opportunistic infections and other HIV-related acute illnesses. Of additional concern is that a large proportion of participants had a low CD4 cell count, a high HIV viral load, were newly diagnosed with HIV, or were not on antiretroviral therapy or non-adherent to the therapy. Our study findings highlight the need for the implementation of innovative strategies to enhance HIV prevention and awareness programs, ART services, and retention in care. The second study, this was our second article on antiretroviral therapy non-adherence, was published in the South African Medical Journal. So ART is associated with improvement in health-related quality of life and a reduction in HIV transmission. Well known, everybody knows that. And we all know that suboptimal adherence to antiretroviral therapy is associated with an increase in viral resistance, opportunistic infections, progression to AIDS, and mortality. Antiretroviral therapy was first made available at South African public sector hospitals in 2004. And as of September 2016, all HIV-positive patients, irrespective of CD4 cell count or stage of disease, are eligible for initiation of therapy. In the study, we utilized the AIDS ACTG questionnaire, adherence questionnaire, to determine ART and ART adherence. It's commonly used, it's one of the most commonly used tools in most studies. So a third of our patients were non-adherent to antiretroviral therapy, and subjects who were newly diagnosed had a significantly lower median CD4 cell count and a significantly higher median viral load, not surprising. Those who had not been initiated on therapy prior to ED presentation had a 69% higher likelihood of in-hospital mortality. So not being on therapy and becoming acutely ill is associated with higher mortality. Okay, so some of the characteristics of our study patients, and we see blocked off in the red triangle, that every year's increase in age was associated with a 3% lower likelihood of antiretroviral therapy non-adherence. Males were 49%, or males had a 49% higher likelihood of antiretroviral therapy non-adherence. And CD4 cell count, less than 100%, so that's meaning immunological failure, was associated with a 5.303 times higher likelihood of non-adherence. Virological failure with a 35 times higher likelihood of non-adherence. And length of hospital stay as well. Participants that required hospital admission for more than 7 days had a 39% higher likelihood of being non-adherent. And surprisingly, although in-hospital mortality was associated with a 55% higher likelihood of non-adherence, it did not reach statistical significance, although marginally. We then went on and inquired from patients what were the reasons for antiretroviral therapy non-adherence. So many studies have been published in this slide, but this is one of the first few to be published from the emergency department setting. And most patients reported that they forgot to take their medications. There were various other reasons, as we can see here, some of them being no social support, mental illness, no transport money to get to the local clinic. In the next leg of the study, we determined predictors of prolonged hospital stay in HIV-positive patients. So this was the publication. Okay, so compared to HIV-positive patients attending HIV clinics, HIV-positive patients presenting to the emergency department are generally more severely ill and frequently require hospitalization and ICU admission. The average hospital length of stay among HIV-positive patients requiring admission varies widely from between 4 to 15 days, depending on the study and the setting. Prolonged length of stay places a significant burden on healthcare resources and costs. So in our study, the median length of stay was 4.6 days, and a third of patients required a prolonged hospital stay, which we define as more than 7 days. So after univariate analysis, we then subjected our data to multivariate analysis, and these were the variables that were significantly associated with in-hospital mortality. Bacterial meningitis, 4.83 times higher likelihood of in-hospital, of prolonged hospital stay, and this is because we know patients with bacterial meningitis usually require 2 weeks of antibiotic therapy. Then cryptococcal meningitis, renal dysfunction, low GCS, and low hemoglobin. And with regards to acute gastroenteritis and bacterial pneumonia, the opposite holds true. That means it was associated with a lower likelihood of length of stay more than, or prolonged length of stay, or length of stay more than 7 days. And that's we all know, because patients with acute gastro or with pneumonia, bacterial pneumonia, receive a few days of fluids, antibiotics, and then get de-escalated to oral therapy, after which they can be discharged home. Okay. We then went on to determine the predictors of in-hospital mortality amongst HIV-positive patients presenting with acute illness to the emergency department. So from 2003 to 2009, HIV was the leading cause of death worldwide, with the annual mortality peaking at just under 1.4 million deaths in 2007. Better availability and improved access to antiretroviral therapy over the past 15 years has resulted in a significant reduction in HIV mortality. HIV currently ranks now as the 14th highest cause of global deaths, from being the leading cause in 2007 to now the 14th highest cause. So we are really doing well globally in terms of the pandemic. In 2019, however, HIV was reported as a leading cause of death in South Africa. South Africa currently boasts the world's largest HIV program, the success of which is evident with an increase in life expectancy from 56 years in 2010 to 65 years in 2014. So high mortality associated with HIV has had far-reaching socio-economic consequences, with there being reductions in labor supply, agricultural productivity, human capital, and national development. And there's also been an increase in widow and orphan-headed households. So previous studies, what did previous studies show? Previous studies reported that the presenting diagnosis requiring ICU admission, a low CD4 cell count, virological failure, anemia, renal dysfunction, low albumin levels, and high lactate levels were all associated, or were all regarded as predictors of mortality associated with higher ICU mortality. So these are some of the data from our study. Firstly, on univariate analysis, we can see all of these variables were associated with in-hospital mortality. These include being newly diagnosed with HIV, ART non-adherent, tachypnea, hypoxemia, shock, tachycardia, and decreased level of consciousness were all associated with an increase in mortality, in hospital mortality. And then looking at some of the laboratory data, we see that also immunological failure, virological failure, then anemia as well, leukopenia, thrombocytopenia, renal dysfunction, all associated with higher in-hospital mortality. CRP, that's our infective biomarkers, and we can see the higher the CRP, the higher the odds ratio for mortality. Same with creatinine, the higher the creatinine, the higher the likelihood of mortality. Lactate, look at this, lactate more than 5 was associated with a 13 times higher likelihood, or 13 times odds of in-hospital mortality. Low albumin, again, the lower the albumin, the higher the mortality, and we looked at ALT as well. We then subjected the data to multivariate analysis, and after subjecting the data to multivariate analysis, 8 variables were found to be independently associated with in-hospital mortality. So comprising of 1 variable from history taking, so asking the patient, are you non-adherent to your antiretroviral therapy, or have you not yet been initiated in antiretroviral therapy? And then from vital signs, there were 3 variables that came up as independent predictors of mortality. So that's respiratory rate more than 20, hypoxemia less than 90%, and GCS less than 15. And then from simple blood tests, or routine blood tests, should we say, creatinine, white cell count less than 4, albumin less than 35, and lactate. And we see the highest being lactate of more than 2 was associated with a 4.83 times higher likelihood of in-hospital mortality. So this led us to the final article that was published from this research, where we developed and internally validated the HIV in-hospital mortality prediction risk score. So what are outcome prediction tools? So validated outcome prediction scoring tools have several advantages. It provides clinicians with some useful information when counseling patients and their families. And also it allows for the selection of appropriate therapeutic strategies, allows for better allocation of scarce resources, allows for timely initiation of palliative care, or is a means of measuring and comparing unit performance, and allows appropriate patient recruitment in research trials. So identifying factors that are associated with unfavorable outcomes in HIV-positive patients requiring hospitalization may be useful for guiding clinical decision-making, directing the allocation of scarce resources, with example with regards to who to intubate, who not to intubate, how far to go with therapy or palliative care, and influencing patient disposition. So should we give this patient an ICU bed, or should this patient be monitored in a ward or discharged home for TLC? So how did we develop the model? So variables from the multivariate analysis, that is the 8 factors that we mentioned, the 8 variables that we mentioned a few slides ago, the independent predictors of in-hospital mortality. These were selected for inclusion in the predictive score. And then we allocated weighting scores based on the regression coefficients, which is the slope for each variable. And this is how we allocated the scores. So we can see these are our regression coefficients. For those variables that had a regression coefficient of less than 1, we allocated a weighting score of 1. And for those with a score of more than 1, we allocated a weighting score of, or with a regression coefficient more than 1, we allocated a score of 2. Okay. So minimum and maximum achievable scores was 0 and 10. So if a patient comes in and doesn't have any of these factors, then the patient gets a score of 0, maybe HIV positive, but all of this is normal, so you get a score of 0, and maximum achievable score is 10. All of these numbers add up to 10. So now that we developed the model, so we have to evaluate the performance of the model before it can be used in clinical practice. So how do we do that? So firstly, we looked at the actual rates of in-hospital mortality for each of the various total scores. And then we looked at the probability of in-hospital mortality. That means looking at the relationship between the risk score achieved and the approximate predicted probability of in-hospital mortality. We then assessed discrimination. So discrimination is the ability of a score model to distinguish between patients with the outcome, in our case was in-hospital mortality, from those without the outcome, that means survival to hospital discharge. And we assessed this using the receiver operating curves. And then we assessed calibration. So discrimination and calibration are both important. And calibration is agreement between observed outcomes and expected outcomes. So observe what we see in the number of patients dying, and expected is based on our risk score, on our tool. Here we use the Hosmer-Lemeshow goodness of fit test to determine calibration, or to measure calibration. And then we had to subject the data to internal validation. So we had to internally validate the model, which means testing the performance of the model in patients from a similar population to the original sample. And here we use the bootstrap technique. And then and the last step is to externally validate the model. So with regards to internal validation, so as we can see, the higher the score, so these are all patients that were scored depending on the variables and number of variables that were positive. And we note that the higher the score, as the scores get higher, the mortality also increases. Right? And if we look at the risk score predicted probability graph, and we can see that the distribution point suggests a positive relationship between the two, between the risk score and the predicted probability. And then we assessed discrimination of the model. So on assessing discrimination, we can see the area under the receiver operating curve is 0.83, which in statistics it translates to good discrimination of ability of the model. Okay. And then with regards to calibration, so this is observed outcomes versus expected outcomes. And we can see for each of the scores, there's very little difference, slight differences between observed and expected. and indicating that calibration was also acceptable. Okay. So how did we internally validate the model? So we assessed it using the same study sample, which is what most other studies do as well. Okay, so we determined again the calibration of the model and the distribution of the model. So what we did is, in our statistician with the magic, she put all of this into one of these statistical tools that we use for the study, and it broke up the sample into 200 smaller samples, each comprising of 670 plus minus study subjects. And we can see that there was a tight distribution between samples with regards to the receiver operating curve, around 0.83, which indicates that the model's discriminative ability did not appreciably change between bootstrap samples. And then the goodness of fit test, again looking at calibration, and this is what it showed, and it indicates good overall calibration of the model. So which means that the study had been internally validated. Now with regards to external validation, so external validation has to be done on a separate another population. So currently a study being conducted at Chris Hani Baragwanath Academic Hospital Emergency Department. A total of almost 1,100 patients have already been enrolled. Data collection has been completed. The data is currently being analyzed with the statistician, so therefore the study has not yet been published. But some preliminary data, and as we can see, as the scores increase, so this is the original study from Samja, the increase in mortality, right? And what's also notable here is that for both the studies, for the Baragwanath study as well as the Charlotte Macheke study, that if a patient has a HIV IMP score of 5, 25% of those patients are likely to die. If your score is 6, a third of patients are likely to die. If your score is 7, half of those patients will die. If your score is 8, 3/4 of those patients will die, and 9 and 10, most patients will die. So we can see between the two studies, the data match quite nicely, and there's very little differences between the two. The differences are less than 3%. Looking at the predicted probability curves between the internal validation on the left and external validation studies on the right, and we can see that the relationship between the risk score and predicted probability are similar between the internal validation and the external validation studies, and the curves also look very similar. Okay? And then with regards to comparing discrimination, also we can see the area under the receiver operating curve for the regional studies 0.83 and 0.78, similar, which is also regarded as good, acceptable and good for both the studies. Okay. And then calibration also indicating good calibration for both the studies, both stats for both show that it's good. So what are the take-home messages? Okay. So with better availability of antiretroviral therapy, there has been a significant reduction in new infections and AIDS-related deaths. However, the burden of disease is still significant. A third of HIV-positive patients requiring ICU admission do not survive. Current ICU predictive models, such as the Apache 2 score, overestimates HIV mortality by approximately 2-fold, and hence should not be used to decide who should be admitted as criteria, who should be admitted to ICU or not. Therefore, there is a need to develop a more specific outcome prediction model that is applicable to HIV-positive patients in the ICU. For anyone looking for a research topic, here is your research topic. Emergency departments are the first port of call for people living with HIV experiencing an acute deterioration in their health. Approximately 1/5 of HIV-positive ED patients are undiagnosed at ED presentation, so about 20%. Another 20% of HIV-positive patients who know their status are not yet on antiretroviral therapy, and approximately a third of HIV-positive ED patients are not adherent to the antiretroviral therapy. So the question is, how can emergency department clinicians contribute to ending the HIV epidemic? And the goal from UNAIDS is to end the epidemic by 2030. Okay? So one is we can actively identify patients who are missed by existing testing programs. So these patients come into our emergency departments. We can identify these patients and not just get them admitted or send them home, but refer them onwards to a program where they can be initiated on antiretroviral therapy, developing closed-loop referral systems. So not just, write a letter to the clinic and say, go there, but a closed-loop system where the patient can be tracked. Has the patient been seen? Did the patient actually go? Was the patient initiated on antiretroviral therapy? Okay. And then implementation of universal test and treat policies in the emergency department. So like how was done in this study, policy at Charlotte is that all patients coming through to the emergency department are offered an HIV test, knowing that 8.5 million people living with HIV in South Africa, and more than 20% of world's HIV population is in South Africa. We definitely need to be testing all of our patients. Every opportunity, needs to be looked at as an opportunity to test patients and to get them onto therapy if they are HIV positive. Okay. And then identification of patients who have been lost to follow-up. So these are many of our patients who had not been on the antiretroviral therapy, who had been initiated, but now were non-adherent. So identifying these patients and some strategies to enhance retention in care. Okay, so in-hospital mortality of acutely ill HIV-positive patients presenting to the ED is still substantial at 13.1%. And simple clinical and lab findings can be utilized to independently predict outcomes of acutely ill HIV-positive patients. So that's our HIV IMP score, the 8 variables that we spoke about. So pending external validation, the HIV IMP score is an easy-to-use tool that can be used to predict in-hospital mortality of patients presenting to the ED, may be used to guide clinical decision-making, direct the allocation of scarce resources, and guide patient disposition. Thank you. Thank you for your attention. Are there any questions?
Thank you, Prof. Relaye, and on behalf of the faculty.
Thank you, Professor Mari. Thank you, Professor
Thanks
Mari.
a lot. Okay, now it gives me pleasure to call upon Professor Firoza Mutara, who is academic head of the Division of Emergency Medicine, to reflect on the presentation that was given and give a few words of vote of thanks.
Thanks. Thank you, Prof. Mahdi and Prof. General. And thank you, Prof. Lahaye, for that very comprehensive talk of what in South Africa is still a critical issue in our healthcare system. In as much as HIV and AIDS has been around since the 80s, and we've all been through the AIDS denialism and the ARV access challenges, it's still an issue that we still need to deal with on our daily, and we as the frontline staff that see these patients on admission still have to deal with it as part of our problems. As frontline specialities in emergency medicine, we often have to deal with these critically ill HIV/AIDS patients that have to make rapid decisions about what we do with these patients. Do we admit them? Do we intubate them? Do we refer them to ICU? And in resource limiting constraint environments that we all work in, it's often a difficult decision to make. And I really would like to hope and pray that now that we have a tool that we could be used that's easy to use with information that is easily accessible. We're not looking at weird and wonderful blood tests and results that will take days to get back. These are all parameters that we can assess easily and quickly in our EDs and hopefully make a difference in terms of what we can do with these patients. We're all aware of, Prof. Richards is here, we're all aware of the extreme limitation of critical care capacity, both in our public and private facilities. So if we have a means of being able to determine what patient would have a better outcome and would have a better longer term recovery, then that would make a big difference. And it would help us to use our resources more appropriately. So thank you for this very important piece of research, and hopefully something that we can implement not just nationally but internationally. And very well done, Abdullah, on that achievement of your PhD. I'd like to take this opportunity on behalf of the faculty and all of us here to invite you to please share in some refreshments after we have concluded. Thank you, Prof. Mahmood.